Right, my name is Peter Voorhees, and I'm from the University of North Carolina's Lineberger Comprehensive Cancer Center. So I'm here to discuss a phase 2 single-arm study evaluating the use of Siltuximab, which is an anti-interleukin-6 antibody, in combination with pulsed dexamethasone for patients with relapsed and relapsed refractory multiple myeloma. So the preclinical rationale for this type of combination is based on the fact that when you incubate myeloma cells with interleukin-6 in vitro, you have a considerable degree of dexamethasone resistance that develops. Additionally, if you co-culture myeloma cells in the context of bone marrow stroma, that also leads to a considerable amount of dexamethasone resistance, and that in large part is due to the fact that interleukin-6 is present within the bone marrow microenvironment, and there are very good mirroring models which would also support the role for interleukin-6 in mediating dexamethasone resistance in multiple myeloma. So with that preclinical rationale in hand, we look to see whether or not a neutralizing interleukin-6 antibody, Siltuximab, would make pulse dexamethasone basically work better for patients with multiple myeloma. So, as I said before, this is a single-arm, open-label, multi-center phase 2 non-randomized study. This was done in the U.S. as well as in the Netherlands. The primary endpoint was overall response rate, so we looked at PRs and better, and we also did look at overall response rate on an ad hoc basis using the International Myeloma Working Group criteria. Secondary endpoints were time to progression, progression-free survival, overall survival, and obviously the safety. Patients had to have measurable disease in order to be eligible for the study. They had to have either relapsed or relapsed and refractory disease. They had to have had at least 2 prior lines of therapy. One of those lines had to include bortezomib, and they had to have documented relapse or no response to their last therapy. They had to have an adequate performance status, and the important thing to realize is that the eligibility criteria with respect to renal function and platelet count and neutrophil count were very liberal. So the way that this was done is that Siltuximab was given at 6 milligrams per kilogram IV on an every 2-week basis using a 4-week cycle. For the first 4 cycles, dexamethasone was given in high-dose fashion. So it was given 40 milligrams on days 1 through 4, 9 through 12, and 17 through 20. And then beyond cycle 4, we just gave 40 milligrams on days 1 through 4 of the 4-week cycle. The way that this study was done is that the first 14 patients initially just received Siltuximab by itself, because in addition to figuring out whether or not Siltuximab would add to the efficacy of dexamethasone, we also wanted to determine whether there was a signal of activity just with the single agent itself. So 14 patients received Siltuximab alone. Unfortunately, we did not have any responses in those first 14 patients. So 10 of these 14 patients had dexamethasone added to the regimen moving forward, and all of the additional patients that went on to the study received Siltuximab and dexamethasone together from day 1. So this is an analysis looking at those patients that received the combination, whether Siltuximab was given by itself, alone, and then with dexamethasone, or whether they got both agents at the same time. Does that make sense? So here are the results. So we have 49 patients that we're looking at here. The median age was 65, which is fairly typical. A pretty good balance between men and women. So as far as disease duration, the median disease duration was 4 years, with a range of 0.7 to 13.2 years. By virtue of the eligibility criteria, everybody had to have had prior bortezomib. Everybody had prior corticosteroids. 90% of patients had received either thalidomide or lenalidomide or both. 90% of patients had received previous alkylating agent-based therapy, and 2/3 of patients had received prior autologous stem cell transplant. Importantly, the median prior lines of therapy, not regimens, but prior lines of therapy was 4, with a range of 2 to 9, and 86% of the patients were refractory to their last line of therapy. And another thing that's very important to appreciate with respect to this particular trial is that 73%, 3/4 of patients were refractory to the last dexamethasone-containing regimen. So the median duration of therapy on this particular protocol was 4 cycles. 47 patients were evaluable for response, and when you look at response rate by EBMT criteria, it was 17% PRs or better. If you use International Myeloma Working Group uniform criteria, the overall response rate plus minimal response rate, in other words, the clinical benefit rate was 28%, and we had 9 PRs and 4 MRs under those circumstances. We had 17% of the patients who had progressive disease on study, and we had almost 60% of patients who had stable disease on treatment. Importantly, of 11 subjects who had obtained at least MR on this particular combination, 5 of those patients were refractory to their last dexamethasone-containing regimen, and 7 of those patients had experienced less than a minimal response on a prior dexamethasone-containing regimen. It's a little hard to take that home to the bank, but it suggests that perhaps in those particular patients that the downregulation of interleukin-6 signaling with Siltuximab has resensitized the cells to some degree to dexamethasone-based therapy. So as far as more long-term clinical efficacy measures, the median duration of response was 6 months. 3 patients had long-lasting responses of 9 months or more. The median progression-free survival in this fairly heavily pretreated relapsed and refractory patient population was 3.7 months, and the median overall survival was a respectable 20.5 months, and the overall survival ranged from 14 days to 37.7 months in all of the patients on the study, and this is just a Kaplan-Meier curve of overall survival. As far as safety is concerned, overall I think that the toxicity profile is quite favorable. I think it's important to recognize that the rates of significant hematologic toxicity, which are shown in figure 2 here, are quite modest, and there's not a lot of other additional grade 3 and 4 non-hematologic toxicity that was seen on a frequent basis. But certainly, all patients experienced some form of an AE, and 3/4 of patients had at least a grade 3 or higher adverse event during the course of the trial. And one of the things that came out was that there was a fairly significant infection risk, which is not surprising in a refractory patient population who's also getting fairly high doses of dexamethasone. So 25% of patients discontinued therapy because of an adverse event, and 40% of the patients on the study had at least 1 or more serious adverse events, and many of those were infection in nature. 5 patients passed away during the study. 3 passed away less than 30 days after the last dose of study agent, and those 3 deaths were due to progressive disease. So there were 2 patients that did pass away due to infection, though. So, to conclude, the combination of Siltuximab and dexamethasone is well tolerated, especially when it comes to hematologic toxicity. Although the overall response rate was somewhat modest, I think it's important to recognize that this was done in a heavily pretreated patient population, and the vast majority of patients on the study, 86%, had relapsed and refractory disease. And I think it's also important to recognize that we did see a signal of activity in patients who you would have expected not to have responded to dexamethasone-based therapy, which would suggest that perhaps downregulation of interleukin-6 with Siltuximab is in some cases resensitizing the disease to corticosteroid-based therapy, although certainly you would need a phase 3 study to prove that definitively.